Hi, I'm Danita Sanborn, and I'm a cardiologist here at MGH and a member of the PO Executive Committee of the MGPO. I'm here with Dr. Inga Lennes, who's a Senior Vice President in the PO for Practice Improvement and Service Excellence. We're here today to talk about the Term 1 Quality Incentive Program measures. So, Inga, I understand that this measure is going to be about service, and in particular ambulatory service. Can you tell us a little bit about that?
Sure. So this term we decided to focus on service because it's so important for the health of our organization and because it's something that affects our patients every day. So the ambulatory units are often the first touch point for our patients who come through the door there, are seen by our providers, and then end up having care on the inpatient side or other places. And so by focusing on that, the data that we collect about their experience on the ambulatory side, we really want to try and start to put some attention to that experience that they have there. We think it's so important, not only for retaining patients, but for building our reputation across the region for the care that we provide every day that's so excellent, and then being able to keep them, those patients here within our practices.
So I imagine that there's some providers who don't actually provide direct service to patients. How are they going to be approached in this QI measure?
So those providers, the providers like, for instance, pathologists, some radiologists that don't have direct patient contact, we don't have the service scores for them through the CG-CAPS metrics that the rest of the providers are being sent as part of our data distribution. But in subsequent terms, as we start to think about service across the organization, those providers will not be left out. Although they haven't received data as part of this first Term 1 QI measure, we really want to include all of the providers in trainings and in the quality improvement projects that we are doing to enhance service, because the work that those particular doctors do, although it's behind the scenes and not necessarily directly touching patients, has a profound effect on the patient experience. When those pathology reports are done in a timely way, when those radiology reports are in and are available to our frontline physicians, it really affects the quality of the patient experience. So I think that the patient experience is something that we're all responsible for, no matter what part of the organization we're in.
Great. So can you tell me a little bit about what a provider might expect to receive in these reports?
Sure. So you should have received this already if you were part of the first data distribution. The way that we've decided to distribute it first is an email, and in that email you see some raw scores, what we call top box scores, which is the percentage of time that a patient chose the very best score for a particular question. And the questions you'll see are regarding the patient experience on the ambulatory side, with timeliness of care, the quality of communication, for example, and their satisfaction with the provider. Those types of measures are there's 9 or 10 different ones that you'll see in the raw top box score distribution. But one of the most novel aspects of this data distribution is that this data distribution also includes the patient's comments, which can be very rich. So they include really detailed information from patients about their experience in our clinics, and those comments are being distributed along with those top box scores to providers.
And tell me, do the scores have any statistical significance, or was there something that we should be shooting for in these scores?
It's a common question. So we collect CG-CAPS ambulatory experience level data, shooting for statistical significance at the level of the practice, not at the level of the physicians. So it is possible that some physicians in the same group, some will receive a high N of scores returned, and others will receive a low N because the sampling methodology isn't equal across all physicians. So these are not statistically significant. We may change that sampling strategy in the future, but for now they are not statistically significant at the level of the provider. But that doesn't mean that they don't give us some information. And I think that anytime we ask our patients to take time out of their day to tell us about their experience, we want to make sure that we're respectful of that time that they chose to give us this information, and that we can review it sort of in that spirit.
Are there any benchmark data for that, for a provider to know what their scores should be, or what others out in the rest of the world get for those kind of scores?
So there's a lot of heterogeneity across the country in how patient experience scores are arrived at, how they're benchmarked. So we don't have any necessarily across a large swath, but we did provide with the individual score reports the aggregate data for your division. So, and we hope that gives you a sense of where your scores lie in relation to at least your whole group, to give some context. But we hope that this is an evolution, that this is just step one in this project, and that in the future we'll be moving towards that benchmarking goal that you mentioned, and giving you some data in the context of where you might lie in a larger group of people.
That's great. Thank you so much.
Sure.